You are listening to Reduce the Stigma, a CJ106 docu-series funded by the Community Radio Fund of Canada. This series aims to provide information on local services, bring to light the work of healthcare professionals, and most importantly, reduce the discrimination faced by people with direct lived experience with a mental illness.
Hello, my name is Jan Eck, and this is Reduce the Stigma. We hope that you find this series on mental health resources in the Westman region both informative and helpful. We are glad to present many issues of mental health and wellness, a topic that in the past had long been discussed in hushed tones or suspicious whispers. Today it seems we are more open to talk about mental health. We want to talk about it because it's something that affects all of us. The more we talk about it, the more we can destigmatize what we had previously held as fearful, unknown, or something that other people went through. For someone who is suffering from mental illness, talking about it might mean that some people are listening. It could mean that their concerns are being taken seriously, but it definitely means that they are not alone. Chances are you or someone you closely know currently lives with a mental illness. Yet, despite an explosion of information in popular culture surrounding mental health, stigma remains a barrier to diagnosis, treatment, and community acceptance. By promoting resources that can help people, by discussing the nature of mental well-being, and by listening to the stories of people living directly with mental illness, we hope to demystify the experience and reduce the stigma against those suffering from very real medical conditions. In this episode, we will be talking about addictions or substance abuse disorders and mental health. In just a little bit, we will feature an interview with Karen Doty-Sweetnam, a professor of psychiatric nursing in the Health Studies Department for Emerging Nurses at Brandon University. It is a fairly recent concept to categorize addiction as mental illness. Maybe it was because addiction was stigmatized as a matter of choice or personal will that it was not fully considered such as a mental illness. This matters not only in terms of access to treatment and resources, but also speaks to societal perception and self-stigmatization. We have become used to hearing alcohol is a disease, yet we often still find substance abuse treated separately from mental health issues. Proponents such as Tim Ayas, clinical medical director of the Clares Home Center for Mental Health and Addictions in Alberta, says that integrated treatment of addiction and concurrent mental disorders produces the best results. Failing to treat them together increases the chances of failure in trying to treat either one alone. Addiction is like some other mental illness in that it is a compulsive activity that is seemingly uncontrollable and often leads to spiraling mental and physical deterioration. Addiction is also hugely linked or comorbid with other mental illness. From the Canadian Mental Health Association website, we learned that around 20% of people with a mental illness have a substance abuse problem, which is twice the general rate, and that rises up to 50% for people living with schizophrenia. Similarly, people with substance abuse problems are up to 3 times more likely to have a mental illness. Depending on the substance being consumed, psychiatric symptoms as diverse as schizophrenia, depression, anxiety, paranoia, and psychosis can be evidenced. Sometimes the symptoms remain after the drug's effects wears off, which often indicates an underlying mental disorder. There is also much to say about misconception and the stigmatization of addiction. It is still commonly thought that addicts are weak, that they have no motivation, or that they contribute little to our society except perhaps making our streets dangerous. This is something that we desperately need to dispel for everyone's good and greater understanding. Just last month, for example, in April 2016, the world mourned the untimely death of legendary artist Prince. His renowned technical abilities, his incomparable work ethic, and his immaculate appearance belied his addiction to opiates. And in too many cases, we find hard-working people who become injured and consequently addicted to pain medication. It's quite obvious that these people do not lack will. They are active contributors to society. And just for a second, let us acknowledge that you can be addicted to so many other things. Addiction is just not about substance abuse. Workaholics, gambling, shopping, and sex addictions are all common to our knowledge. But what do they have in common with substance abuse? And what is it then that causes addiction? Why are some substances more addictive to certain people than to other people? How can one drug bring one person to disaster, yet another person can consume the same drug regularly without apparent harm and is able to easily quit? And seeing that people can become extremely obsessed with almost anything, what exactly is an addiction? These were some of the questions I had when I sat down to interview Karen Doty Sweetnam, professor of psychiatric nursing at Brandon University. Doty Sweetnam has recently presented her published research on successful addiction recovery events as related by women of First Nations ancestry, and I was excited that she would be able to share her results here. She will also discuss addiction treatment from the traditional abstinence models to emerging harm reduction techniques, and what advice she gives to graduating nurses when it comes to treating people with addiction and mental health issues. Let's start with a brief introduction, your name and position with Brandon University, the courses you teach at Brandon University, your own education training, background experience, and what led you to teach psychiatric nursing, especially in regards to addictions.
Hi, Jan. Firstly, I want to thank you for the opportunity to do this interview with you. I've been a long-term listener of yours and I've really enjoyed your show. For me, I'm an assistant professor at Brandon University in the Department of Psychiatric Nursing, and I've been teaching here for 8 years. Prior to that, I did clinical work for 27 years, and prior to that, I was just living my life. I have had a long-term interest in the field of addictions for the very basic fact that I'm Korean Irish, and if you know anything about the Korean Irish, going down that path, I come from generations of substance abuse and misuse within my family members. As a small child, I recognized that other people don't live like that. And I decided that I would move forward and get education and training in this area so I could understand it at a deeper level. I'm a registered psychiatric nurse and I have a master's of education.
Why and how is addiction a mental health issue? Explain how mental health is affected by substance abuse and addiction. And can we distinguish between addiction masking an underlying mental illness as compared to mental illnesses brought upon by substance abuse?
Substance abuse fits under the category of mental illness or a mental morbid illness. And so what you're looking at is you've got addiction as a subcategory of mental health. And within that, what you're looking at is you have this bunch of mental illnesses, and then you have the different addiction processes. They can work together or against one another in many ways. And the treatment that we need to look at is a comorbid treatment in which that we look at, is there a mental illness? Is there a substance abuse problem? And if we're looking at it from a best practice point of view, within both of those, we're going to treat them together. Very hard to be healthy if you're being under the influence of one addictive substance or another. Mental health is about living a balanced life. And when anybody is involved in some type of addictive process, they're not leading a balanced life. Something is not balanced for them. So they're doing something to fill that void. And that can be a myriad of different types of addiction. But within that, it will affect the day-to-day health of that person physically and mentally.
The nature of addiction has, in the case of alcoholism, been called a disease. Why is it a disease?
I love that question because it's certainly one that's been out there for debate. The easiest way for me to look at it, Jan, is that if we take the word disease and we cut it up into two parts and we moved from the first part, which is discord, where something's lacking. And the second part is ease. So what we're looking at is ease. So if you ask anyone in an addictive process, are you feeling ill at ease? Then what you are is you have a disease process. Further to that is what you have to look out is what happens after the addiction. Is during that addictive process, there's many physiological processes that get damaged. With those physiological processes that get damaged, we end up with lots of different types of diseases. And so hence the medical community has referred to this as a disease. When I talk to people who are or have an addiction, one of the things that what we have noticed is when we use a disease approach, it helps them have a better understanding rather than that this is by choice. It lets them know that this can be equal to having many other mental health issues. This is just one of them.
Before we go further, let's make sure we briefly mention all the different ways one can be addicted. There's substance abuse, and there's behavioral addictions as well. Could you expand upon the myriad ways we can be addicted?
Pick a substance, Jan, and some people can be addicted to it. It's as simple as that. What we're looking at is more of a process than what we're looking at as a specific substance. People are addicted to shopping, they're addicted to stealing, they're addicted to sex, they're addicted to food. There's so many things that people are addicted to. It can be simply chocolate. It depends on the impact, whether we refer to it as an addiction and problematic or not.
Can we distinguish addictive behaviors such as shopping with other mental disorders such as OCD, which is very compulsive and obsessive? How do you distinguish between an obsession and an addiction?
Well, Jan, those can be actually close hand in hand because part of having an addiction is being obsessive. Is that when you wake up in the morning, it's the first thing you think about until the time you go to bed at night. And that's one of the defining criteria about it being addictive.
What defines addiction?
Is when we're looking at, especially on the psychoactive substances, what we're looking at is that there's a physiological and a psychological dependency. And so there becomes a requirement that the person needs it, or else their body is going to get sicker without it because they've become dependent on it. Now, when we're looking at some of the other behavioral addictions, they're not going to die without it, but they have those obsessive traits within it. Now, if we cross back over to a person who has OCD, is they are trying to reduce their anxiety in doing the behavior. It's to make them feel better. But that's a different way than addiction. In addiction, what we're looking at is a person generally wanting to create more dopamine in their brain, which we will talk about in a later question. And with that, so we'll talk about the dopamine levels and people being dopamine seekers. And it's a quest for that dopamine to help them feel better and be happier. Where for the person with OCD, what you're looking at is anxiety reduction.
Getting into causes of addiction, some people are susceptible to certain addictive substances or behaviors, while others may be immune. The case of American soldiers during the Vietnam War is the big example. Many soldiers apparently used heroin extensively, but did not become addicted, while some people can become addicted quite easily. What does this tell us about addiction, or even the addictive nature of the substance or behavior itself? What makes a person susceptible to a substance or addiction to a substance or a behavior?
Well, that's another one of those loaded questions, Jan, that requires a lot of dialogue, but I'm going to try to put it into a shorter form. So we talk about vulnerability and susceptibility in addiction. So, for example, you have someone who is born to a healthy mother, who is raised healthily in a healthy family. They go out into their life, they experience a traumatic event. Most likely, we're not going to see them be the person who's going to go out and get addicted, because that's not a previous pattern in their life. Who is more susceptible, or to those people who there's a genetic predisposition? We know that we have Asian people, are North American Indian. There are more people that tend to process the substance differently than the average person. So with that, what happens is we have those who will do a substance on a one-off basis. Then we have people who continue to do it. Those are more susceptible people. Also, I think what can't be missed in all of this is susceptibility has been looked at as far as age of onset. When we're looking at age of onset, we have people who don't use substances until they're in their teens. And then what we end up having are younger people who have started using at a very young age within the home. And you are more vulnerable the earlier you start any substance. When we look at the Rat Pack case of the people over in Vietnam, that case has been quite extensively researched. And what they have realized is the men that went there did not have a pre-existing condition of addiction. They went, they used a substance, and when the horror of what they were experiencing was over, they quit. And we can find that throughout history. It really goes back to the individual person and the susceptibility of pre-birth, birth, early years, and into adulthood.
Susceptibility to addiction occurs during very many developmental phases. So can you predict a susceptibility to addiction by early childhood behavior?
When we look in the field of ADHD and ADD, that is one of our biggest predictors. For those youth, what we have found for the children with those diagnoses, they are at a predisposition. And part of that comes from the social aspect of it, comes from the fact that we're asking them to fit into classrooms that don't fit for them. There may or may not be family of origin issues. And again, we look at age of onset. I have worked in the field of addictions for 35 years, and I have actually found small children who use substances. Where would a small child get it from? Is their parents. So if we have a history of parents with substance abuse and a child who can get a hold of that substance, that's where the roller coaster begins. And often within the early system, if we're looking at what is the home foundation, what was the birth history of these kids, and then what is their success in school? Later on, what we have seen is they are the ones that in the teen years start using. And because that's the one group that everybody fits. So the using pattern behavior begins and it goes right on into adulthood. And so when we're looking at susceptibility and vulnerability, we're also looking at coping stances. And because these youth are not learning other coping mechanisms, what we're looking at is there's the susceptibility, vulnerability for any crisis that goes on in their life.
Lots of new theories are thinking about addictions, such as from Dr. Gabor Mate, celebrated physician who deals a lot with childhood development and addictions, suggests that underlying childhood trauma creates a profound need that substance abuse or other addictive behavior satiates. This profound need is part of a spiritual void, according to Dr. Gabor Mate. Can you tell us what that means and describe how childhood trauma could lead to addictive behavior?
Well, if you go back, Jan, there's things called the ACE study, which is the best study that has ever been out there, and it did a longitudinal study of children in looking at early trauma and how it affected them in later life. What we know is the neurochemistry of the brain is highly affected when children are raised in traumatic circumstances. It affects the growth and development of the brain, and it affects the chemistry and how it communicates back and forth from one cell to another. You mix that together, then you end up with that predisposed, susceptible individual that moves forward into an addictive pattern. And so it starts right back from very beginning. The other thing that we have to be cognizant and very open about in our discussions is we have a lot of families that use a lot. And when they use a lot, that's what the children see. And that's what the children learn to cope with. They learn that when you're happy, you drink or use. When you're sad, you drink or use. And so given all that together and you put it in the blender, you've got that susceptible person. Now, if we look back to Mate and the spiritual void, is what happens to these people is they don't get grounded in their relationships with themselves or with other people. And so for my culture, we look at people being grounded to Mother Earth. So they're grounded to their culture, they're grounded to tradition, they're grounded to the land that they walk on. That piece is what we call spirituality. People mix the two of spirit and religion. Religion is the practice of a set of rules and guidelines in a more formalized state. If we're looking at spirituality, we're looking at the part of us that relates to all things. And if we have not had healthy relationships along the way that relate to all things, what is described as that spiritual void, your lack of connectedness, which has nothing to do with religion, has everything to do with how you feel about other people, yourself, how you feel like you will operate in the world in the future.
And addictions fill that spiritual void by providing a warm, fleeting comfort temporarily. But let's get more into the internal chemistry of addiction. Can you explain how the internal chemistry processes work to affect a person's susceptibility to addiction?
What we're looking at again there, Jan, is that we have discovered through doing tests and things like that in the scientific community that there are those people who process substances different than other people. And we've even been able to go as far as discovering groups of people such as our First Nations people. They metabolize alcohol differently. So what it looks like is for an average person, alcohol will hit the body and they go, all right, I'm enjoying that or may not enjoy that, but they recognize it's a poison to their body and their body will accept maybe one or two drinks. What happens to the person who is in the addictive mode or is an addictive person is it turns into an opiate in the brain. And the opiate so it goes from the body in the tummy, gets metabolized, goes into the brain, becomes an opioid, just like when you're looking at your T3s and all those things that they're talking about. It becomes that for them, so they get an extra kick. And most people who go back and reflect on, for example, drinking their first time, will say, if they're predisposed to addiction, it's like they came home for the very first time. It is different processes for different people. Okay, so for those people, it turns into an opioid in the brain. And what we're looking at is the chemical piece in the brain that people go after in addiction. Let's take one step back from that picture. We've got the opiate. We know that it is metabolized different. What we also know, though, is we have little chemicals in our brain called neurochemistry. Neurochemistry, you've got your serotonin, you've got your dopamine, your norepinephrine, all of those brain chemicals that make us feel happy, make us feel well, make us feel better. For someone who is prolonged in substance abuse, you will find that their neurochemistry has been affected by the fact that it decreases. So if you have someone who, for example, has serotonin, which helps us be happy in life, if they're drinking a lot or using substances, it decreases that serotonin. That decrease in serotonin makes that person depressed. So now you've got a depressed person who's using substances. And conversely, what we've also got going on in the brain is the whole dopamine factor. And the whole dopamine factor that's that feel-good, yee-haw thing that makes us all want to do the things we do, such as sex and food. That all makes us feel really good. That's dopamine. There are those among us who are dopamine seekers, and they are always looking to replenish the dopamine in their brain because their brain is not making enough of it. So they do things such as substance abuse to try to increase those dopamine levels, but it works to their disadvantage because their brain won't catch up unless they stop taking those substances in. And that's when we look in the difference between depression and substance use. Hard to figure out if somebody is depressed or they have a substance abuse problem when they're using, because it's affected their neurochemistry. And has it been affected because they were previously depressed, or has it been affected because they're using so many substances?
All right, the effects of addictions are immense. People lose their jobs, their families, their physical and mental health deteriorates. Many lose their lives. People around them are impacted often traumatically, but sometimes the effects of addiction are more subtle. And these are some of the defining characteristics of addictions, and we've also mentioned a few earlier. But what else defines addiction? And what signs are most noted amongst addicted people? That could be like weight loss, loss of interest in other things, some other bad behavior. Could you expand upon that?
Addiction not only harms the individual, it really certainly most likely harms the family, the community, and larger society. We've got the cost effect of addiction, so that costs our healthcare system. We move to the community level. It affects the effectiveness of the community when you have members within a community who are addicted to substance abuse of any kind or misuse. So if we look at more on the individual level, what we look at is it affects, of course, the person's finances. They may end up doing such things as stealing, prostitution, to be able to keep themselves within their substance. You're looking at mood swings. So, for example, you're working with someone and they are chronically mood swinging because of their substance abuse, can make it very difficult for a side-by-side working relationship. You're looking at, if you take apart all things physical, all things spiritual, all things mental, all things emotional, everything gets affected, Jan. Nothing gets left behind. Addiction hurts more than anything else the person and the people around it. If, for example, we have someone who we're trying to identify in the workplace might have a problem with alcohol, we can look for things such as absence from work. Do they smell? Are they unkept? Do they remember conversations that they've had with people? Their work productivity goes down. Judgment and reason can be impaired in the workplace as well. So it depends on the position you have. Judgment and reason is maybe not as problematic if you're working in a place like 7-Eleven, but if you're a nurse like I am, you want people with good judgment and reason doing your medical care.
I hope in discussing the previous week understand the importance of seeking treatment, and there are many ways to treat addictions. Let us begin with the more traditional, can I say, model of abstinence. So, can you briefly describe the 12-step program? And this is the basis of Alcoholics Anonymous, correct?
Yes, Dr. Bob and Bill W. are the starters of AA, and that was back in the 1930s. And today is an amazing program, and I'm going to give a good plug for all of the 12-step programs because I think that they're the only place that someone can go get help outside of the medical community on a regular basis and sometimes 24/7 because the people of AA do what's called 12-stepping, and once they've had a period of time in sobriety, they in turn go back and help others. It's a wonderful program for doing that. So when you're looking at the 12-step program, what they're looking at is a series of steps that a person goes through to be able to deal with their substance abuse. So there's Alcoholics Anonymous and there's Narcotics Anonymous. Then you get into the support programs, which are ACOA, which is Adult Children of Alcoholics. You've also got Al-Anon groups. And those are for the support groups for those loved ones who have been affected by the using person. Within all of those steps, what the ultimate goal is abstinence. And if you look back to the first step of being powerless over the substance, that puts the person actually into a huge place of power because they're recognizing they can't control this and need help. So that is a non-professional program out there. You can find it most nights a week in all communities. There has been jungles in Africa where you have been able to see AA signs. You can go on a cruise ship and they will have AA meetings. So that is your basis of the abstinence program. Is the goal is for the person to quit the substance use and use these 12 steps. For some people, they're going to need more than that, Jan, because of the pathway that they're on. And what they may need to do is go to detox first, which means that is a place where they go to get off the substance that they're on. And that can last anywhere from 1 week to 6 weeks, depending on what they're detoxing from and the substance they're detoxing from as well. And then we can go into treatment programs, which can go from 30, 60, 90 into a year or even 2 years. Now, when we're looking at all of these programs, what we're looking at, there's private programs and there's public programs. Public programs are paid usually by the province or the federal government, where the private programs are paid by either the employee or the individual. And so generally what happens is the person, depending on who they are, whether they're working or not, will end up going into a position of needing help, and depending where they're at that moment of time will depend the service that they seek.
Okay, well, sometimes there are people that have really struggled with their addictions and cannot make a clean break with their addictions. And in this case, a lot of people have recommended what is called a harm reduction model. Can you expand further on the concepts of harm reduction model and what its advantages are?
You've reached my favorite topic, Jan. I am a self-proclaimed harm reductionist and I teach from that place. And why I teach from that place is I find it to be the most compassionate way of being in the world. Is there those people out there who for some reason or not are unable or unwilling to be able to move away from their addiction. And we as a society, I believe strongly, have a role to play in those areas. So when we're talking about harm reduction, what we're talking about is policy program and practices that look at you don't have to be abstinent and we will find a way to help you. However, in saying harm reduction is not an abstinent model, I need to remind people that at the end, there's still that secret hope, wish, and a dream that that individual may live long enough to maybe quit their substance and live life a different way. And that harm reduction actually provides us as healthcare professionals or as family members the opportunity is to see this individual get well. So a lot of people think that harm reduction actually started in the 80s, but it was much earlier than that, as we actually saw our first harm reduction program in Canada back in 1964 with the first methadone treatment program out of Ontario. Then it laid somewhat quiet for quite some time, and in the 80s, what happened was this recognition that people were dying and we weren't able to help them. Medical intervention was coming in at the wrong time. We were coming in post-mortem. So what has been a decision is that we needed to bring in programs in place that would help people live to a more abundant life. That began in the mid-80s. And so in the mid-80s, what we started seeing was different models of harm reduction pop up around the world. So the UK started in some harm reduction. And then in 1989, we saw the needle exchange in BC. What all these come down to is the fact that harm reduction reduce costs. I'd like to say the government moved this direction because of the love of people, but it is for the love of finances. Harm reduction saves money. We're not spending as much time and money in the emergency room. Harm reduction helps people do better longer. All of those things contribute to a better society. I want to tell you a quick little story of the best harm reduction program I know out there. And it is over in the Netherlands. And what happened there was a park in the middle of this community, and it was full of people who were drinking and using all the time. People felt unsafe to use this local park, and it was always a complaint. Someone came up with the idea, I'm not sure who it was, but they decided to go to the community within the park and say to them, how can we do something more positive together? And what they put together is the park people who were also the addicted became the employees of the local community. And they became responsible for cleaning the park, making sure the park is safe, people were safe in it. And how did they do that? They rewarded these individuals every hour with an ounce of alcohol. So all day long, their physiological needs, psychological, emotional needs were met, and they felt value. Over time, they see a reduction in use of these people. There's pride. These people are wearing outfits of pride. They are park workers. They've taken a whole community there and made everyone feel valuable. We could be doing things like that everywhere. It's a small example, but big gain.
Right. In the 1980s, there was also the explosive HIV infection rates. Part of that was due to sharing needles. So this seems to be quite relevant to the emergence of harm reduction as well. Like a part of harm reduction is safe site injection sites, for example. That are even in Vancouver, I do believe. Safe injection sites. Is there other aspects of harm reduction that you could talk about?
Well, we've got the harm reduction. We've got the smoking programs. The smoking oil programs are all harm reduction related in that they're all trying to get you to cut back, cut down, and then eventually quit. But that is done on a harm reduction model as well. And the model actually that all of this has come from needs to be recognized in our conversation. And it's the work of Prochaska and DiClemente. And the work of Prochaska and DiClemente was about change process that goes along with harm reduction. So you decide to help people cut down or reframe their using, but at the same time you interject with services that are appropriate for the time. And that's when we get into the work of Prochaska and DiClemente, and where they started was with the stop smoking programs. On the bigger scale, when we think of harm reduction, of course, we are looking at the needle use practices and safe site injection as well. As let's use Vancouver, for example, I'm sorry I don't have the stats for you, Jan, but there was a tremendous amount of death down in Vancouver related to injecting with dirty water, injecting unsafely, and also what happens when they overdose. What we now know is people aren't dying. And because they're able to go to this safe place, get a clean kit, they do their injection with supervision, and if they have a profound reaction, someone is there to save them. The other thing that they're looking at right now is actually bring Narcan, which is a substance that counteracts if somebody overdoses. They're looking at trying to make Narcan available on the streets of Vancouver as well. And the Narcan, so that if there's someone on the street that didn't make it to the safe injection site, they themselves could administer the Narcan, or a person that's with them, and save their life as well. So it's moved all over in different ways, harm reduction.
Also, when a client accesses safe site injection, that they are made available so many other resources that will help them with their mental health and well-being, and physical health as well. You have completed research with Indigenous or First Nations women who have excellent recovery stories and have been able to theorize what has helped them to control their addictions. Could you please explain the research you undertook and what are your supported conclusions?
This again is another favorite topic of mine. What has happened for me, Jan, is I'm a recovering alcoholic of 20 years. I'm also Aboriginal. And what I have recognized is, although I have worked in the field of addiction for almost 35 years, I rarely see Aboriginal people in the mainstream. And I started asking people I know that were sober, in particular women, how did you get sober? How did you get sober, and how did you get sober? And why I ask those questions is I myself did not go through formalized treatment, but I did go to AA. So I was curious, how do other Aboriginal women get sober? And that was my question that I went out to find the answers. When I went out to meet Aboriginal women and have that discussion, what came back to me is that our medical system is not working for Aboriginal women. They are not making use of it to get well. They are very clear they feel uncomfortable in the medical community and with medical professionals, and that includes psychologists, psychiatrists, doctors, and nurses. So the system we have set up as care for all people is only exclusively working with some people, where when I asked the question to the Aboriginal women, how do you get sober and stay sober? That's the piece that was important, is every one of them got sober through a spiritual path. And if we look back, when we're talking spiritual void, spiritual path for them did not mean religion. It meant going back and getting in touch with their cultural roots and practices and understanding who they are and how they walked in the world. From that research, what I was able to disseminate is the things that we're actually doing as a public health community is not meeting the needs of Aboriginal women in Manitoba. This research was specific to Manitoba. And what was also very important in this study, it was the relationship with another sober person. They come on their pathway, meet another sober person who says, I will take you by the hands. And with that guidance, that's how every one of these women got sober. And certainly that was my own experience as well. So my question was answered, is that Aboriginal people are not making use of programs that have been based basically on white man medicine as opposed to native medicine. And that's where we need to go back to for Aboriginal women.
What kind of help can people with addictions find in the Westman region? Are there different treatment methods available? How important is social and other network support? We just basically talked about that. And how can one build a team for recovery?
Well, for the public go-to place, Jan, is we've got our Addictions Foundation Manitoba, which is right down by the hospital in Brandon. Across Manitoba, there are various places, all under the umbrella of Addictions Foundation Manitoba. They have services for residential, there's driving awareness programs, there is individual counseling, and there is a residential treatment program right here in Brandon. Where we have a lack of service in the Westman region is with detox. I was just actually visiting with someone from Sioux Valley yesterday, and to go to Sioux to be able to get treatment, for them, they will need to go to Saskatchewan away from their home community and family to be able to get help. And that doesn't work within the First Nations or Aboriginal communities. So we also have private therapists that are very good in this community who also will see people as well. But as with all things, it's all very limited. Everything has wait lists. Everything has to be done in a timely manner. And if you're dealing with addiction, my belief system is you move fast and furious when the person is in need of help, as opposed to waiting till the system being ready for them.
When you were talking about the recovery stories of Native women and what worked, you mentioned about another sober person. So this leads into the question about how important having social and network support is in terms of recovery. Can you describe how important that is, please?
The ideal situation, Jan, would be a support team around every individual who has an addiction. Unfortunately, that's not what happens. The places of support don't necessarily have all the means to be able to support, for example, the family unit. The individual may be able to get support, but it's left out the other family members in the treatment process. So, a person with an addiction most definitely needs to find themselves in a sober community, and they're going to have to go out and find that and work hard for that. We have a heavy using society, whether it be from cigarettes, alcohol, marijuana, to cocaine, to the other drugs that are out there. People use, they want to increase their dopamine. So, you've now got an individual who cannot artificially increase their dopamine. So, what they often do will cross addict, or they will be able to take that pathway of recovery, but they need that support. And the only place I know you can get that is possibly within, say, a family, a church group, NA, and within those systems. If you have in the Westman, for example, a comorbid condition, say schizophrenia, and you have a drinking problem, you will see mental health and addiction, and you may be able to get services that way. However, if you're a lone alcoholic out there and you're looking for supportive services, it's going to be hard to find. AA is great. The challenges are, I will put this one forward, is you are dealing with people who are unwell. And so sometimes there's unwell behavior that goes on within those groups. And one of the things that was identified by my Aboriginal women was the predatory behavior, particularly when they're a young, gorgeous Aboriginal woman going in to get help, and what they leave with is the men chasing them. And that becomes hugely problematic. So the social support system that's supposed to be there because of the unwellness of some people isn't there. So that needs to be advised. And that strongly came out in my research as well, is that there's not a lot of protection out there for women with addiction.
All right. So what I'm saying, to find a sober community is very important for an addict. Other people need to rebuild their lives to fight their addictions, and this might mean losing some friends who might be contributing to their addictions, or it could mean that the person has to change their lifestyle, at least for a time being, till they reorient themselves and recover a bit. And this must affect a person's choice in dealing with their addiction. It must be difficult to choose between friends or a cherished lifestyle and one's health. Do you have anything to say to this?
Yes. One of the hardest things to do, Jan, is when a person gets sober, is where do they go after that, especially if they come from an environment that people are using a lot in. So that can affect their family and friendships. To be able to stay well, people need to leave those relationships behind. I will use my own self as an example. 20 years ago, when I chose to quit drinking, it was like having to make a major life plan change. I left behind friends who also chose to leave me behind because I wasn't fun anymore. And I had to leave family behind as well, which, as you're aware of in the Indigenous community, can be quite problematic when you start cutting out family members because you need to put your sobriety first. But what we all know is without the sobriety coming first, it will never happen. And so those sacrifices need to be made. One thing that will help with that is if you get into a supportive group of recovery and possibly an individual counselor that can help you work through those relationships. But it is what happens. You will lose friends, but what you do is gain relationships and something at a deeper level. Those choices are what have to be made. I remember a story from one of my Aboriginal women that she had quit drinking, was just finished detoxing, and her son showed at the door with a 24-pack of beer. And she opened the door and she looked at him and she yelled, "Get out of here and don't come back here ever again unless you're sober." And the wonderful thing about that is he did leave her. A year later, he joined her in sobriety. And that's the other thing that people also need to hang on to, is they may feel alone, but it generally starts affecting the people around them, and other people may join them.
How do people with addictions struggle with social stigma?
That's huge, Jan. I was thinking about that question last night, and I was thinking about Aboriginal people. And if there's a Native person walking down the street and they stagger, what is anyone's first impression? They don't think this person might have diabetes and that they're going to fall to the ground because their blood sugars are low. They think they're drunk. There's certain groups of people within Canada that we assign that behavior to, and it is a big social stigma. In my research around women and alcoholism, that is the biggest preventer of women getting well. And I know from my own personal experience, it has only been in the last few years that I have been able to come out of the closet as a sober person, in spite of the fact that I've worked in the field and that I have 35 years of experience. Is my own bias prevented me from being strong enough to come forward. And I have determined that if I, as a professor and a powerful woman, cannot speak about my own addiction, how difficult it must be for someone who's much more vulnerable.
Do people with addictions face discrimination in healthcare settings?
So much, Jan. Being working in the nursing field for as long as I have, I see it all the time. It can come from a nurse deciding to withhold a pain medication because they will use the terms, "that person is drug seeking." People like to determine for other people how much they should use and when they should use. It is huge in discrimination. You go into the ER, people are withheld meds. People will not get certain treatments because they show up intoxicated. Even within the field of psychiatry, there is often really unkind remarks made about people with addiction. And that's been I think probably the biggest drum I have been beating for as many years as I've been involved in being more proactive around the addictions community, is the fact of being the cruel part of people that wants to look at these individuals as being dirty, nasty, and wrecking society, instead of coming from a compassionate place of, how can I help you?
What about friends and family of people living with addictions? How are they affected by stigma?
Huge, Jan. You will find people hiding their family's addiction all the time because it's like they're carrying that shame as well, because we've not reached a place yet where we've taught people that this is not a self-imposed thing they're doing to hurt other people. Until we reframe what addiction actually is, we're not going to be able to move beyond how it affects other people, because they're carrying the shame of their family members. It hasn't really changed in 35 years since I came into the field. I still hear it within my classrooms, people's attitudes and behaviors towards those who are addicted. My colleagues who find working in the field of addiction very difficult, probably one of the most difficult areas to work in, because of the trauma and tragedy within the family units.
As an instructor for an emerging class of professional psychiatric nurses, and especially regarding your courses on addiction, what understanding do you hope to install in students?
For me, it's two things. One, please don't go into the field if you feel punitive towards people with addiction. We have enough doctors, nurses, and healthcare professionals out there who feel prejudiced towards those who are addicted. So please don't go there, because there is enough people out there who want to work in a healthy way. For me, the biggest message I want to send to my students is all about compassion. Unless we come from a compassionate place, we can't deal with this. I do not believe this is a choice. Maybe the choice was in the first drink they took. 20 years later, that choice is gone. And I believe very strongly in the premise that we need to step up and help people from all aspects and walks of life, and that where we need to find the most compassion is within healthcare.
Professor Karen Doty-Sweetman, thank you very much for this excellent and informative interview.
Thanks, Jan. This has been my absolute pleasure.
That was Karen Doty-Sweetnam, Professor of Psychiatric Nursing of the Health Studies Faculty at Brandon University. I hope this information was helpful to your understanding of addictions and mental illness. My name is Jan Eck, and you have been listening to Reduce the Stigma.
You are listening to Reduce the Stigma, CJ106 docu-series funded by Community Radio Fund of Canada, narrated by Jan Eck, produced by Jan Eck, Matthew Higgs, Tyler Addison, and Janice Brohl.